just picking up on the intermediaries, because I want to go to the price in a second, but the intermediaries, one of the things that one of our coalitions found was that not only is it in these high-priced drugs, but it's in the low-value drugs where things seem to be askew, where things are being covered that shouldn't be covered for no other reason than the business model rewards low value. And are you seeing that type of thing? And a corollary to that, there's policy discussions right now about moving away from a rebate model. What are the implications of that? Is that a good thing, or is that a concern?
I don't think I would know that yet. I know that it has lowered our costs by having direct share in rebates. We pass that on population-wide, so we have at least an interim concern. If we were to reverse that, it would benefit patients, but we'd also have to increase our costs across the total population. So it feels in many ways to me sort of like sin money. We'll buy a lot and you'll give it. It's a kickback, right? Let's call it what it is, a kickback. And so they're a little unnerving to begin with. I think I'd really rather just have transparent cost and guarantees. If I were creating a slightly more perfect world.
Yeah, I think the rebates, they serve their purpose, and so like we're saying, we need to move from fee-for-service. We need to move away from rebates. They've served their purpose. Now they've become a little bit skewed in the wrong way. The transparency needs to be there, but also the rebates are inhibiting probably effective drugs for people. So new drugs may come out for rheumatoid arthritis. Well, they're not, they already got the rebates with these two drugs. Well, we're going to just put this as a higher tier. So then it's a barrier for that patient that's the drug that's best for them. So almost it's taking an axe to something that needs a scalpel right now.
Yeah. Agreed. It's a one of a series of I think reasonably not so transparent components of contracting that makes at least me inherently suspicious of the delivery system. And when we look at financial performance, should we be surprised that large healthcare companies are have tremendous revenues? What are we missing? A transparent model would help us to at least better understand how the pharmacy supply chain is working and where there may be some other opportunities for us to perhaps more effectively align our mutual interests.
Let's talk on the pricing side of the thing. The prices. Some of those prices we hear and we read about are being driven in part because of the need to generate rebates. But what we're paying here in the United States versus other countries is outrageous. Is there a need for us to somehow push back on that? I mean, how do we deal with that? I mean, there's policy proposals, but it seems to me we've kind of given a blank check, and it continually gets abused. And how do you deal with that issue?
I don't think as individual plans we could deal with it. I think that's going to take a real volume effort. Yeah. We're not directly negotiating with pharma, so we're kind of outside that negotiation path, and directly contracting would be meaningless from any organization as an individual organization.
And maybe from the coalition. I know, coalitions are, and other groups are combining to directly contract with hospitals. Why wouldn't you come as a coalition and start directly contracting with manufacturers? Maybe it's something, if they feel like they're squeezed out of the PBM by a tier, they may be open to this too. I don't think anybody's really asked that question.
Yeah, I think one of the challenges has been how to disrupt the status quo, and is there a big enough entity, and I think this is where coalition certainly could have a role, to think much in the way that we have created, or the marketplace of third-party administrators has evolved relative to health plans. Maybe there's an opportunity for a pharmacy benefits administrator that simply processes the claims data for pharmacy claims, and the direct contracting is done by, for the purchase of the drugs, as you suggested, is done by another entity.
Yeah, I don't pretend to say any of these are simple issues, but to say that there aren't issues here would be a misnomer too, and it's a big area that we're trying to get our hands around too, in terms of where to take it.
Well, I really worry about the affordability for patients.
Yeah.
Because for most patients taking most drugs, they are the difference between a quality life and a less quality life. I mean, they just are. Yeah. Most people don't take drugs just because. They're actually treating something, and particularly diabetics. I mean, I hear story after story about the expense of just managing type 2 diabetes, between test strips and insulin and doctor's visits and eye exams. It's a really expensive disease, and we want people to be adherent. So the affordability issue on drugs is particularly, I think, is a patient-centered issue.
I think you raise a really interesting point, and coming back to a topic of earlier discussion, the issue of prevention, I think, is critical. And much in the way with oncology, earlier detection of cancers can be potentially curative. Similarly, earlier attention to management of the pre-diabetic could potentially mitigate the need for some of those diabetic drugs. And I think that's, again, where primary care has a significant role.